I wanted to say good morning to everybody who's on this. I'm Frank Phillips. I'm at Rush University in Chicago, who are excited to be hosting this innovative format and probably the wave of the future. I want to thank the Seattle science people for putting it together and the pioneers of this, who are Mike Jensen, I think, and Jack Ziegler. Great idea. So we're trying a little bit of a different format, a true traditional journal club. Myself and Dr. Howard On is my partner and the head of the fellowship program in Rush will be doing this. We're going to actually present some papers, have the fellows present the papers, and then spend 5 minutes discussing them. And you can text your questions. And if we'll try and leave a little time at the end, because it'll take a while for questions to come through, and then try and address them at the end, and we'll get all the brain power on this webinar to comment on their opinions, thoughts on some of the articles. We'll have each fellow just introduce themselves, tell us where they're from, a sentence or two on their background, and then we'll get going. So we'll start off. Our first presentation is Christian Khanna, who is going to present the first article you see up on the slide deck. So Christian, go ahead and introduce yourself and get into it.
Yeah, sure. So my name is Krishna Khanna. I'm one of the fellows at Rush. Thanks to the Seattle Science Foundation for getting us started. I was at San Francisco for residency and heading to Boston next year for practice. So the article I'm starting with is about back pain and the quality of life after surgical treatment for AIS with 5-year follow-up. It's an article out of Finland. A little bit of background. Natural history studies have shown an increased risk of back pain in untreated idiopathic scoliosis patients compared with healthy controls. Functionality, though, is considered to be similar between the two groups. Gold standard for the treatment of AIS is posterior spinal fusion with pedicle screws, but it remains unclear whether surgery provides superior long-term back pain and health-related quality of life results compared with untreated AIS. So the objective of the study was to compare back pain and health-related quality of life between patients with AIS treated surgically, and then the other two control arms were patients with AIS treated non-surgically, as well as healthy controls without scoliosis. The hypothesis was that surgery would result in lower back pain and higher health-related quality of life compared to patients with non-surgically treated AIS. Methods here, they tried to include 55 patients between 12 and 19 who underwent surgical treatment of AIS with pedicle screws. It was a single institution and a single surgeon who performed all these surgeries. Outcomes were radiographic. They used SRS-24 for the health-related quality of life, pain scales, and reoperation rates were also recorded. The untreated AIS cohort, patients with a Cobb angle of 10 degrees or more and a scoliosis of idiopathic origin were included. They were matched one by one for age, sex, and type of scoliosis. And they were actually recruited from a different institution, so a slightly different outcome metric was used. They used SRS-22 for this cohort. And here are the results. They ended up including 49 patients in each arm of the study with 5-year follow-up. What you can see is that the preoperative Cobb angle in the treatment group was about 53 degrees, and in the untreated AIS group was 30 degrees. They obtained a pretty decent amount of correction, 78% correction in the surgically treated group. And then at the bottom there in the orange square, you can see that the majority of the cases were Lenke 1 and 2, with a few cases including lumbar or thoracolumbar curve. So this is a table that shows the improvement in patients who underwent surgery, and you can see that the pain, function, and postoperative function all improved significantly from the preoperative time to the 5-year follow-up. And here's the real table that the paper is going for, which is the comparison between the 3 different groups: the surgically treated group, the untreated AIS group, and the healthy controls. You can see that the pain is significantly improved in those with surgically treated AIS compared to untreated AIS. And activity is also significantly improved in the surgically treated group compared to the untreated group. Function was the only difference really between the surgically treated group and the healthy controls. Otherwise, in all other domains, the surgically treated group matched healthy controls. So the discussion here, the surgery group had lower back pain and improvement in quality of life compared with untreated AIS patients. Pain, self-image, and activity scores in the surgery group are similar to healthy controls. And then another thing that came about from this is that pain is a real component of AIS. Preoperatively, 31% of patients rated their pain as moderate to severe. Strength of the study, an identical technique was used in all surgery patients, and so they were all done by the same surgeon. There was 5-year follow-up and consecutive enrollment. And some weaknesses were that there was a slightly different questionnaire used between the two different groups, SRS-24 versus SRS-22, but they did a pretty good job of matching the questions. And then there's some amount of selective bias. Patients who were on the brink of surgery were given the option for surgery versus non-surgery. So there's some amount of performance bias there. And then another weakness I'll just add is that 5 years of follow-up is very good follow-up, but still certainly not enough when you're looking at some of the more larger natural history studies of scoliosis. And just some of these implications, I think this concept of AIS just being a cosmetic surgery, I think this does a good job of showing that we actually are helping these patients. Pain is a real component of AIS. It's unclear why, since the common reasons of back pain like DDD, facet arthritis, and stenosis don't exist in these patients. So largely thought to be a muscular cause. This study did combine thoracic and lumbar curves, which is complicated because I think as you increase the length of follow-up, surgical outcomes of lumbar fusions may be different. And then last thing I would add is this paper kind of, does it start us on a slippery slope where should we be considering treating AIS patients with curves smaller than 45 degrees since the untreated arm in the group had curves that were averaged about 27 degrees and yet had worse health rate, quality of life, and worse back pain compared to the surgically treated group.
All right, thanks, Christian. So why don't we go to Howard? Howard, your thoughts? You're gonna do anything different based on this paper?
Yeah. Hi, everybody. Sorry for a little glitch in the beginning, but anyway, Christian did a nice job summarizing the article, and I like this article because of a couple of reasons. Number one, it has control, not only control but two controls, right? So you're comparing with obviously less severe curves on non-operative group, and it changed my practice a little bit in that for the borderline cases, like if I have a patient with a 45-degree curve, 15 years of age, I tend to be kind of conservative, because it's not going to progress that much, and we tend to neglect the back pain component. We don't ask the back pain that much, and we just follow these patients, and they don't progress that much, and we don't see them anymore. So we just assume that they are doing fine. That's sort of my treatment for these borderline cases. But after reading this article, as Christian has said, I don't think we should operate on non-indicated cases like 35 degrees. But for those borderline cases, I'm thinking again, maybe we can do not just cosmetic deformity improvement, but their function improvement as well as less back pain. So I'm thinking those borderline cases, I can be a little bit more aggressive to at least talk to the patient about doing surgery rather than being conservative like I've been doing. So that's number one. And the another comment is this back pain, because our perception is AIS coming with no back pain, and that's not true because all depends on what type of back pain. When I lecture about the back pain associated with deformity, we talk about the three patterns, right? You got the muscular type of pain on the convexity of the curve, and then that progresses to sort of spondylosis, motion segment pain in the concavity of the curve, which is more significant. And then obviously you could have a worsening back pain down the road with the radiculopathy or flat back type of symptoms. So I think in the adolescent, we are talking about sort of muscular in the convexity, maybe in the concavity in the lumbar combination, but low back pain is an issue. And the 30% have it, and we improve their back pain. Another thing is that when we do surgery, we don't promise them their back pain get better. In this cohort, they got better. It's down to 15%, which is same as the normal group. So I think that this is a good article. That's sort of my summary.
Yeah, so my concerns is just the controls are so different. There's so many factors that go into surgery, and a group that decided or were recommended against surgery, and then you talk about back pain 5 years later. I'm just troubled by strong conclusions of those controls. But Let's Izzy does this surgery a lot. What do you think, Izzy? Is this now? You're like Howard. You got a back pain operation now.
Well, Frank, we've been working together for many years, and you know that I'm not one to jump on back pain operations. But it is a good article. As Christian pointed out, it does emphasize the fact that a lot of these adolescent bullies do have pain, and they come presenting with that, and it is multifactorial. It may not necessarily be the curve. The big concern that I have with this paper is the surgical treatment, in fact. They've mentioned that some of the curves were instrumented below L1. But if these are all selective thoracic fusions and we're just straightening the spine, therefore uploading the lumbar spine, that may be something to consider, and they should break that down in the article. If, on the other hand, these are curves that are being instrumented well down into the lumbar spine, I do think we need a lot longer follow-up to really determine what the benefits are going to be down the road for these patients, or potentially the detriments for these patients down the road. And then we'll be able to say, yes, we should be intervening sooner, or we shouldn't be intervening at all in this group of patients.
Yeah, good point. Looked like someone else was going to say something.
Yeah, Frank, I was just going to say that, of course, I don't do the deformity, but certainly we see Izzy every Friday showing his cases. And I think that the slippery slope that your fellow had mentioned is probably the most important part of this article, because if we start doing more surgery in these younger folks, and there are some problems with the study, they're going to end up having more surgery in the future. And I think I would err in conservatism, and I know Howard's a very conservative surgeon, and I don't think that you should change anything that you do based on this article. It's just one article.
Yeah, and they talk about a little in the introduction discussion. I mean, there have been other papers showing sort of no difference. So just hard, because in that group where we tend to treat the more advanced curve surgically to get a good control, other than some type of historic control with different outcome measures and maybe different trigger to operate. But certainly I think what everyone said is true, that we tend to probably downplay the back pain in these patients, and maybe it's more of an issue than we think. But yeah, I don't think
Can
we're
I ask
ready.
a question?
Of course.
Yeah, so the question I have is, and again, like Rick, I don't do deformity, and I haven't seen kids' deformity since I was a resident Scottish Rite. But, we never really talked much back in the day about pain with adolescent idiopathic scoliosis. So my question is, has it been looked at, the component, like Izzy said, multifactorial, of learned behavior? Of, your parents keep asking, wow, that must hurt. Do you hurt? Is there a psychological component to back pain in adolescent idiopathic that just kind of goes with you your whole life, that you just learn it early? Is that something that's ever talked about in the literature?
I've not seen anything mentioning that or looking at it from that component. That would be something interesting. We could get Dr. Block to start pulling all the records on our kids that we've done and see if he can tease out that factor.
Yeah, it's not. We're actually, one of our researchers recently wrote like an editorial type paper in, I think it was the European Spine Journal, and literature synthesis. And back pain in kids is actually a lot more common than I think we all sort of think about. We think it's crazy adults, but kids have back pain without huge pathology on imaging anyway as well. So probably an area we need to think about some more. But why don't we, that was a good discussion, so let's move on. Next up is Sapan Gandhi, who's going to introduce himself, and he's going to present the treatment of stable burst fracture patients.
All right. Thank you to everyone for joining us this morning. I'm Sapan Gandhi. I did residency in Beaumont in Michigan. I'm headed to Beth Israel in Boston this summer for practice. I'm going to be talking about switching gears here a little bit to trauma. I'm going to be talking about conservative versus operative treatment of stable burst fractures in neurologically intact patients. This is a Turkish study that was published this month in Spine. So, we all kind of know how common thoracolumbar burst fractures are, and by definition, they involve the anterior and middle column. Half of these patients don't have a neurologic deficit. And when we use some of our common measurements to guide us, like the TLIX, they can sometimes fall in that in-between range where the decision is sort of based on surgeon preference or patient preference. So there's ongoing controversy about surgical and non-surgical management for these morphology fractures in neurologically intact patients. So this group did a retrospective review of 45 patients aged 80 to 60, and they focused just on AO classification A3 or A4 thoracolumbar burst fractures that were neurologically intact, and all of them underwent either a short segment posterior spinal fusion, either 1 up, 1 down, 2 up, 1 down, anywhere from 2 to 4 levels, and they were allowed to ambulate immediately afterwards, compared to 12 weeks of TLSO brace treatment, where they weren't allowed full ambulation until about 1 week after injury. It's a single institution study. There were 2 surgeons involved in the care. And what they looked at was radiographic outcomes, a minimum of 3 years post-op, but they had up to 8-9 years of follow-up in some patients, and clinical outcomes measures, ODI, VAS, JOA, and SF36. So what they found, this first table kind of compares their demographics. So the operative patients tended to be a little bit younger than the non-operative patients, and the study doesn't, and I'll get back to it, but the study doesn't really mention why they thought that was the case, or they didn't compare them statistically either to figure out whether or not it was a statistical difference or not. But you see also for their radiographic results, in almost every measurement that they looked at, including sort of segmental kyphosis, both at 1 year and final follow-up, that the operative treatment group did better. They had less kyphosis. And they also had less vertebral body loss, which they measured as percentage of the anterior body and the posterior body height compared to the non-operative group. But when they looked at clinical outcomes at final follow-up, there was no difference between the operative and the non-operative group. They did pretty similarly. Overall, this group found that their surgery group had quote-unquote better radiographic outcomes in neurologically intact burst fractures. They found less kyphosis and vertebral body height loss is what they consider to be better radiographic outcomes. They touch on sort of like global alignment. The only measurement that they did for that was they looked at SVA in all these patients, and they found that even the patients with quote unquote more kyphosis were overall balanced and had normal SVA sagittally. They also found similar clinical outcomes measures between surgical and non-surgical groups. Strengths of this study, I thought one good thing about this study was they looked at identical fracture morphology and neurologic status in a decently sized cohort of patients, which is not present in the literature right now. I mean, there are studies looking at burst fractures, but they usually have a heterogeneous fracture morphology, and tend to compare apples and oranges in some papers. But weaknesses, they really didn't explain why their operative patients were younger, or how exactly they made their treatment decisions. And it was very oddly phrased in the paper. Patients who underwent surgery were decided on surgery, and patients who underwent non-operative management were decided on non-operative management. So it's really unclear whether it was surgeon preference, whether they educated the patients and they made the decision, or what the factors were in deciding how they decided operative or non-operative management, which can give the potential for selection bias. And although all the patients got quote unquote short segment fusion, there were some variation in the number of levels that they fused in these patients. So overall, for this fracture morphology, you can expect equivalent clinical outcomes in comparing operative and non-operative management. They do talk about superior radiographic outcomes, but I'm a little unsure of what to make of that. Is it just that we don't like looking at kyphosis on postoperative radiographs? Like, does it actually make a difference to the patient? So I think at this point, the main thing I take away from this is that trying to educate the patient on what to expect, or similar outcomes between non-operative and operative management, and kind of trying to get everyone on the same page as far as that. I'm not sure what else to take away from this compared to the rest of the literature.
So, Sam, before we go to Howard for comments, just reminding the paper, I forget, did they talk about complications in both groups? I don't think.
Yeah, so they said they had no complications in the surgical group or non-operative group.
Yeah, I say in a retrospective study, it's hard to imagine, if like you do a high quality study, there are going to be all kinds of complications that come up, and we don't know, but you'd expect some of them maybe to be higher in the surgical group, which adds to the cost, et cetera, et cetera. But anyway, let's go to Howard. Howard, thoughts on this article?
Yeah, so Safan did a nice job. This burst fracture, the Telix 4, the stable burst fracture has been controversial for 30 years. Francis Denis came out with the article in the 80s showing the operative was better for return to work and activities, so it became very popular to treat surgically. And as you know, the article that we cite quite often is Kirk Wood from Boston, now in Stanford, and he compared the conservative versus operative.
Sorry, Howard. Sorry to interrupt. I'm getting a message. People are having a hard time. So what I think we're supposed to now do is, if you're not speaking, mute your microphone. I think it's affecting people hearing the talks. So if everyone not speaking, and then just click on when you speak. Sorry, go ahead, Howard.
All right, so I'll try to speak a little louder. So what I was saying was, Kirk
it's not that. It's a technical thing.
All right, Kirkwood's paper is conservative versus operative, and actually conservative is better. But you have to, if you look at those two studies very in detail, I'm talking about Kirkwood, the average kyphosis was like 20 degrees for non-operative, whereas this article is about 10, 11 degrees. So we're not talking about exactly same severity. So I think this article is dealing with patients with less kyphosis than Kirkwood's conservative treatment. So bottom line is that in both cohorts, operative did not do any better. Of course, they make the kyphosis better. So the topic is still controversial. So what do I do in practice? I think that we have to individualize, and everybody knows some of the indication for surgery, like multiple trauma victims, right? That's obvious. And some patients are not fit for orthosis or body cast. These patients cannot wear brace well. And then some patients cannot deal with the pain. I mean, trying to ambulate with the brace on, pain is too much. They cannot even get out of the hospital. So there are some cases that obviously need surgery. And in terms of kyphosis, for me, 10 degrees, I don't even think about doing surgery. We're talking about 20 degrees or more. And then I also look at other things like comminution. Dr. Gaines published a long time ago about the degree of comminution of the fracture that has some bearing on kyphosis and future outcomes. So Gaines classification I look at. So I think this article doesn't add to the resolving any controversies, and we need to individualize this patient. That's my take.
Yeah, I mean, the question really is, what's the long-term value of 5 degrees of improved kyphosis? Obviously, surgery is presumably on the front end much more expensive than conservative treatment, and there are likely to be some surgical complications to add to the cost. So what's the value? Let's get some other opinions. Mike, what do you think?
Frank, before Mike gets in, can I just comment also, there's a downside to doing 4-level fusions on otherwise healthy young spines. So the figure 1 that's in the article showed an L2. I'm not even sure it's a burst. It was a superior end plate anterior little fragment that I think most of us would have braced. And they did a 4-level posterior fusion on that. So there's a downside to a young, healthy person now living their life with fused segments that would not have been fused if they treated it conservatively. That has to factor into this as well. So it's not just, is it worth making a pretty x-ray for a few degrees? And what's the downside in 15 years for, this potentially 20-year-old person who's now got a multi-level fusion? So I just got to keep that in the back of our mind also. It's not just choose A or choose B.
But to get more practical, Mike, what do you see these patients with a burst with, say, some 15 degrees, 10 degrees kyphosis. How do you make it neurologically intact? How do you decide, who to operate, who not to operate on? What are the factors you would think about?
You're going to be a candidate for a non-operative. But I think the key that Jack mentioned for me is the most important. When you look at those constructs that have the multi-level reconstructions, even if we've tried to do a multi-level to fix it and then take the hardware out later and thinking that we're going to benefit it and still save motions, in my hands hasn't worked real well. So when you see patients, especially like in Colorado, that, have these ski accidents and have these levels like this, I think the key is, can you in your hands do a simple surgical procedure, save the most amount of levels, benefit the patient compared to these, putting them in a brace. But I would only do that if I could, unless it was multiple trauma, unless a patient I can segment, do very short segment fixation and still get a good outcome.
All right, one more. Rick, are you still there? How do you treat them?
Most of these are, in my opinion, are treated non-operatively. There's not a neurologic deficit, no significant progressive deformity. Most of these can be treated very well non-operatively, as Howard described. I mean, Kirkwood's studies have been seminal and show quite well that if we can treat them non-operatively, they're going to do better than operative treatment.
All right, so I think there's pretty good consensus on that as Rick prepares for elective emergent surgery there. All right. Who's up next? It's Evan Sheehan is going to talk about PEEK versus allograft for ACDF. Introduce and go, Evan.
Name's Evan Sheehan, one of the fellows, obviously. A little technically challenged. I did my training at HSS, heading back there afterwards if New York City's still around. I have the ACDF PEEK versus structural allograft paper out of UCSF. So just a little bit of background here. These came out of the market as alternatives to iliac crest, mainly because of the comorbidity profile for the Harvest. And then PEEK cages themselves gained popularity as an alternative to allograft because they're biocompatible. They have a similar modulus of elasticity to bone, radiolucent, they have a long shelf life, so a number of perks there. But there have been some conflicting outcomes in the literature regarding pseudarthrosis rate with PEEK. So this group decided to look at their 2-year fusion rates, looking particulate subsidence, reoperation, change in alignment for 1 to 3+ level plated ACDFs using PEEK versus structural allograft. So this is a retrospective 2 attending case series. They had 168 patients representing 264 levels from 2005 to 2017. So some of their notable inclusion criteria, only patients with 2-year follow-up with imaging, either X-ray or CT, and only degenerative etiology, so no infections, tumor, trauma. And then notable exclusion criteria, they excluded any hybrid constructs using PEEK and structural allograft. They excluded any integrated fixation or screws through the cage. Patients with greater than 5 degrees of kyphosis were also excluded. And then no crest or BMP as fillers. So the outcomes they looked at were pseudarthrosis on X-ray or CT, subsidence, and then change in lordosis. So the overall results here, you can see there were more patients who had structural allograft than PEEK. But the overall pseudarthrosis rate by patient and level are similar and not statistically significantly different. They also, at the bottom there, height loss or subsidence and lordosis loss were also not different when these were grouped together. Looking now at pseudarthrosis by treated level. So overall, they had 19 cases of pseudarthrosis. There were 3 total operations. 2 of those were in the 2-level group and 1 in the 3-level group. But there on the left, no difference in pseudarthrosis rates based on cage type at any level. And then in the graph on the right there, their pseudarthrosis rate by number of treated levels. So breaking it down to 1, 2, and 3, it was sort of similar to what we see in the literature. So no surprises there. And then looking at pseudarthrosis by cage and graft type, so they broke this down into peak versus structural allograft, and then autograft or DBM with autograft. They again found no difference in fusion rates based on the filler type. It should be noted there's a high proportion of autograft used versus the DBM and hybrid, which might be make it difficult to draw any conclusions from that. And then finally, looking at subsidence loss or lordosis, there's no difference in subsidence or lordosis loss for the 1 and 2 level cases. They did see a significant difference for loss lordosis for structural allograft at the 3 level, but there was only 3 patients or 10 total levels treated with peak. So that sort of precludes any significant analysis there as well. So the takeaways here, 1 and 2 level ACDFs, there's no real difference in pseudarthrosis, reoperation rates, or subsidence, change in alignment based on the cage type or graft material. For 3 level ACDFs, they did notice significant loss of lordosis with the structural allograft, but there really was low numbers, so you can't really make any conclusions there. Strengths of this study, they had a 2-year follow-up. They noted in their discussion that previous reports of higher pseudarthrosis rates in peak, there was only a 1-year follow-up reported. So they felt like looking at 2-year might have changed some of those outcomes. They also had strict indications. So it's a very tight package of the type of patient that they're looking at here, which I think allows them to draw some good conclusions about peak versus structural allograft in 1 and 2 level cases at least. Limitations here, they had CT scans for some, but not all of the patients. So that may have changed pseudarthrosis rates to some small degree, though they did use dynamic X-ray. It was underpowered to detect differences in the subgroups, especially with filler types. And then when you get into the 3+ level groups, there's no patient-reported outcomes, though it is a pretty reliable procedure. So I'm not sure that much would have changed there had they included it. And I think that the strict indications, which are a strength, are also a limitation in this case because it's not very generalizable. It's a very specific group of patients that they talked about here, so that limits the conclusions that can be drawn. So in summary, the interbody choice for this particular patient cohort doesn't seem to affect pseudarthrosis or subsidence rates. It really was underpowered to address DBM or hybrid filler types, and it gives more support for expected pseudarthrosis rates for 1 to 3+ level ACDFs. And the question we always ask is, does this really change practice? I don't think so. If you use peak, you'll probably continue to do so. If you had success with structural allograft, you'll do the same. I know Dr. Ahn has a lot to say about graft type choices or graft interbody choices, so maybe he could weigh in as well.
Okay, Frank, you're muted.
Thanks, Evan. Yeah, there we go. So let's get Howard's comment. It seems like it's a controversial issue. I mean, every week a company comes out with a new biomaterial, nanoporous, micro, something, and it keeps jacking up maybe the costs and not always with real solid data to support it. So yeah, so let's hear what Howard says, and then we'll sort of go around and get people's opinion about this.
All right, so the first thing I want to say is, for pseudarthrosis, good outcome, and radiographic outcome, there are many other factors that are probably more important than the graft type, such as, the end plate preparation, the amount of distraction, and type of plate you use. For me, rigid plating really gives you better healing and so forth. So that goes without saying. So you have to do a good carpentry, good surgery. That's the most important. Now, after you did that, whether you put peak versus allograft, really depends on. This is nothing new. This literature shows you equivalent results if you do good surgery. However, there are many types of allograft, right? I think the authors use basically a structural allograft, put something in, and I think for me, when I use allograft, I tend to use corticocancellous frozen allograft, which gives you structural as well as cancellous bone healing. So for me, not all allograft is made equal. And even now, even PEEK, has a porous type and different types giving better outcomes. So if you're going to use whether it's a PEEK versus allograft, have little thoughts about what type of allograft you choose. So I think it's a reasonable article, but it's nothing new in the literature. And I just want to stress the importance of carpentry and surgical technique.
Thanks, Art. Rick Geyer, what do you think? What do you use? What do you think?
Rick, you're muted.
Can't hear you, Rick.
Okay. Frank, as you said, there's been a lot of advancement in the bioactive implants. And when you were making your comment, I was thinking about the porous PEEK, which has been shown actually to work. And now you have all the different porous metals that also seem to work. What we've migrated to is, rather than the allograft, which we had a pseudoarthroses with them, we now use a standalone. At least I can speak for a couple of us. And we use a standalone that is PEEK with the metal coating and the porous coating, and then has screws. Because number one, we found that the patients had less trouble swallowing after surgery, because as much as you try to conform your plates, it's still very, very hard to keep them from not standing up from the vertebral body. Insurance companies makes us use plates and allograft bone. I think it's Aetna, and I'm happy, very honestly. So I think that to use technology, and even though you say it's expensive, when you consider utilizing the various allografts and all the DBMs, it probably amounts to about the same thing.
Yeah, so I think, and I'm going to provoke Rick Sasso in a minute, but I think, I think one level, the comment is probably pretty accurate. I mean, the risk is probably the multi-level, and Rick and I were on a debate about a year ago, so I'm interested to hear his opinion, where he kind of, and I'm quoting you correctly, Rick, he said he's got no 2 and 3 and 4 levels that ACDFs ever heal, and he adds screws. So I actually went back. I've been using porous PEEK for about 3 years now, and I went back, and it's going to be in the literature, Rick Sasso, and we had about 43 and 4 levels, only 3 and 4 levels, and I think we had one pseudo at 2 years with porous PEEK.
How did you determine pseudoarthrosis rates?
Same as this study. I mean, we didn't do CTs, but we had no reoperations, flexion extension.
Stop right there, Frank.
Yeah, well, hang on a minute. But if you see, you can argue about how accurate X-rays are, which I agree. If you put a plate on, you're very seldom going to see flexion extension motion. But if you use all those criteria and they're not symptomatic and not having surgery, I'd argue you don't need screws. Anyway, Rick, what do you do? Multi-level ACDF or multi-level anterior pathology that could be treated with ACDF?
Allograft in a plate. But let me tell you my biggest concern about this study, and it's just what I said, how pseudoarthrosis is determined. Using plain X-rays is a horrible way of determining pseudoarthrosis, and especially how they determine it. They don't even say what they use in regards to motion. They said they use flexion extension X-rays, but how much flexion extension did they allow? How many millimeters? They didn't even say where they measured. Did they measure spinous process, distances, changes in the distance, and how much? So, and you have two guys, probably the surgeons who were the operating surgeons. And when you have two guys who are the operating surgeons looking at their X-rays, guess what? There's a high chance that they're going to say that it's fused. So unless you're using CT scans in this day and age, I don't know how you can actually publish a reasonable article that's looking at pseudoarthrosis.
Can I add on? I'd add on to what Rick has said, and not just CT scans, but quality CT scans with both sagittal and coronal reconstructions. Because sometimes we send patients out for CTs, their insurance company sends them to some crappy place, and you can't tell. You're sending them to look for a pseudo, and you can't tell because they haven't done the proper workup. The other thing I was going to say is it's interesting. We've learned during this Armageddon in telemedicine, we're seeing a lot of our follow-ups now and kind of skipping the x-rays and just doing telemedicine. And we used to make fun of the Europeans that just put the hardware in, did ACDF, and they never saw them again. And they might not all be that wrong, because if the patient's not symptomatic, and you're not going to do a CT scan unless you're doing a study for academics. It's symptomatic is what we're really trying to figure out. Is patient has symptoms, then you do the workup. So it's nice for academics to have the flexion extension, CTs, et cetera. But in the real world, you're really treating the patient, and if they're doing fine and their X-ray looks okay, it may be an asymptomatic pseudo, but it's stable. Maybe we're over X-raying these patients, in our follow-up. At least that's what's occurred to me during doing this telemedicine and having them skip X-rays if they're doing okay.
Yeah, I think that's really a good point. We need to move on, but I see Vincent who's on the text and says that one of the issues is that with subsidence is a wider footprint, and he questions whether a lot of the manufactured allografts are wide enough, meaning at least or greater than 17 millimeters, which is probably a valid point for both fusion and subsidence. Anyway, in the interest of time, let's probably move on. And I believe I got a text. Jens Chapman himself is somewhere out there and has a quick question. So Jens, thanks for putting this together, and welcome, and let's do it quickly.
No, let's move on. Everything has been said. I just wanted to point out that in that article, the 3-level ACDFs had the highest rate. So this is still a very big deal, and I think it was addressed before. So let's move on. I agree.
Sorry, I didn't call on you. I didn't know you joined us. All right, next up is Arash Sayari, one of our residents who's about to do a spine fellowship one of these days. So he's going to talk about posterior foraminotomy versus ACDF.
Yeah, good morning. Thanks, Dr. Phillips. My name is Arash Sayari. I'm one of the 4th-year residents, and I'll find out where I'll be going for fellowship in a few days, so we'll see. The title of my paper is Posterior Cervical Foraminotomy versus ACDF in Patients with Cervical DDD with Radiculopathy. It's a 5-year outcome from the National Swedish Register, and it's a multi-center study. A little background here is that in cervical DDD with radiculopathy, 2 of the options include ACDF and foraminotomy. Obviously, I think this is, how do I get back? Sorry. It's the wrong. There it is. Okay. So obviously, ACDF has a broader range of indications when compared to foraminotomy, but it's not motion preserving, and that's really what's thought somewhat to influence adjacent segment degeneration. And PCF, on the other hand, is motion preserving, and so therefore the study group aimed to compare the 5-year clinical outcomes in NDI and VAS between the two. They hypothesized similar outcomes between both groups and no difference in adjacent segment pathology. So they prospectively collected data for 11 years from their Swedish spine database between 2006 and 2017. They included patients with disc herniations or foraminal stenosis with radiculopathy. They took all ACDF all comers, so autograft, allograft, standalones with plates, without plates. They excluded patients with myelopathy or instability. They collected pre-op, post-op data, and then they sent questionnaires at 1, 2, and 5 years post-op. Interestingly, they used a detailed predictive model to fill in their missing values, so information they didn't gather, and it ranged how often they needed to use that, but it was as high as 16.8%, which I'll touch on later. This figure 1 here just shows their consort diagram here, where they matched it down to 570 matched patients in each group. And you can see here in table 1, the only difference between the two groups was the length of stay between them. Otherwise, they were use a propensity score to match them. And here in this figure here, this table here, you can see all the way to the right side that there was no difference in their VAS, NDI scores, in their other outcome measures that you can all see on the right side. There was no significant difference. But this is really the money page here, I think, pointing out that the PCF group had 10.6% wound issues compared to 3.4% in ACDF. That was statistically significant. And revision surgery was more common in the foraminotomy group at the index level, but there was no difference when looking at the adjacent levels. And they mentioned that the reoperation at the index level was for residual stenosis. And then overall, they found that at any level, index or adjacent, that there was also significant higher incidence of that in the PCF group. So in conclusion, there were more same level revisions in the foraminotomy versus ACDF group, but there was no difference in adjacent level surgery. There was no difference in the primary or secondary outcome measures, which was somewhat different than what they were identifying in the literature, which suggested that motion preservation would reduce the risk of adjacent segment degeneration. I think the strong point of this paper is that they use a registry system that captures more than 90% of the spine patients, which does improve some of the generalizability, especially in their population. However, again, it doesn't necessarily apply across to the United States, possibly different patient population, different insurance model, and some of those things. Additionally, it's a registry, so again, it depends on reporting by surgeons, and that may vary exactly what goes in and what comes out. They didn't use any imaging modalities in evaluating these patients, which I think is definitely a weakness to the paper. And then we don't know exactly the type of surgery that was taking place posteriorly, whether it was MIS, endoscopic, open, and that can obviously play a role in some of the wound issues and some of the things that they had mentioned in the paper. Finally, they had a loss of follow-up of 33% by the 5th year, and again, they used some of the missing value predictive model, but I don't know how much weight I would put into that personally. Implications. So is the question that kind of ask ourselves now is motion preservation the key to understanding adjacent segment degeneration? I think we know that there's a lot of factors that play into this, and just highlighting that we maybe need to better understand some of this. But personally, I don't think that this paper would change my practice. I think I just would want to maintain the indications for posterior cervical foraminotomy, positive Sperling, minimal to no neck pain, more arm pain without kyphosis, avoiding it in athletes, those kinds of things. And then understanding that posterior cervical foraminotomy does have some limitations as well, maybe hard to reach osteophytes or medial herniations and such. But I think we can use this information to educate our patients about their expectations at 1, 2, and 5 years.
Thanks. Nice review. Howard, what do you think?
Yeah, so Arash did a nice job because I harp on the residents and fellows about the indications for foraminotomy, and Arash just spit it out very well. When I did my fellowship 32 years ago at Jefferson, I learned how to do laminar foraminotomy from a neurosurgeon, Fred Simeon, and ACDF from Rothman and orthopedic surgeons. So I knew how to do these operations from the beginning. But when I started practicing in Wisconsin, I didn't know the indication. I didn't know who to pick and which patient. So I had to kind of learn the indication myself. And basically, bottom line, if you're going to have an excellent results with laminar foraminotomy, which I do today, is you have to know the indication, in my opinion. It's predominantly arm pain. Everybody has a neck pain, and also chronicity of neck pain. If I have a patient with 4 years of neck pain now develop C7 radicular pain for the last 4 months, that patient gets ACDF. Whereas, they've been asymptomatic about 3 months ago, wow, severe neck and arm pain, that means 90% of their problem is radicular. And as Arash mentioned, has to have a no kyphosis, positive Sperling's maneuver, and be careful of doing laminar foraminotomy in a professional athlete. I learned a long time ago, if you operate on a football player, hockey player, wrestler, they keep their, banging their head, they come back. Revision surgery is very common. So I try to avoid professional athlete. And so that's the bottom line. So this article is, there's a problem with the registry. I can go on and about registry issues, but if you have a good indication for laminar foraminotomy, which is around for last 4 years, they have an excellent outcome. Obviously, ACDF has more broader indication. You don't have to worry about, kyphosis, and they can have a neck pain, bilateral symptoms, and so forth. But good or bad, I think the laminar foraminotomy is being done less and less, maybe in part due to the, artificial disc coming on board. But I still think it's a good operation if you select the patient right. That's my 2 cents.
Yeah, I agree. I mean, I think it's all about patient selection. And the truth is, not these days, a lot of people are not trained to do foraminotomies. They don't even think about it. I mean, I do a fair amount down the tube, which I think takes the depth of that posterior cervical wound out. But, it's just funny. We all say we've got our separate indications, but surgeons just won't give up on that ACDF. They love doing it. It's a easy, effective operation. So they all say we choose, but then they go, we'll do an ACDF. But it's just funny. But let's get some other opinions. Jack, maybe, and then Izzy. Jack, what? So we don't need disc replacement. Should we just do foraminotomies? And adjacent segments seem to be about the same, whatever you do.
An ACDF is an operation that fixes all sins. You do decompression, whether it's central or foraminal, stabilizes it, realigns it. It fixes everything. And as you said, it's such a comfortable operation that I think most of us tend to drift towards it. But as Howard was exactly right. If you can find the right indication and you have the technical expertise, particularly minimally invasively, then I think that's it's a slam dunk. But you can't widen or over broaden your indications for foraminotomy and expect it to be as successful as an ACDF, where you can over broaden your indications and not even do such a good job and still have a good outcome. So ACDF is just such an easy tool to have in our belt that I think everybody tends to drift towards it.
Izzy, go ahead.
Just to expand on what Jack had said, ACDF is a very standardized operation right now. And the concern that I bring up and what I've witnessed over the years, those that are promoting the posterior laminal foraminotomy, the extent of the surgery, the technique of the surgery. Are you just doing a fragmentectomy? Are you just unroofing the nerve? Are you doing a complete discectomy? I believe there's a much broader scale of what you are doing there. So I think it's going to be much more difficult to really refine the indications to what you're actually doing surgically in that group. And that's what was disturbing about that paper, where they really didn't break down what exactly are they doing. Are they taking the whole disc out? Are they just unroofing the nerve? What are the technical details of the surgery itself?
Yeah, I mean, I think that's a great point. Like Jack said, ACDF doesn't really matter. It forgives almost all sins, whereas I agree, a foraminotomy is technically challenging, and hunting out a disc fragment with a little narrow space around the nerve is hard. So, Scott, how do you choose between foraminotomy, ACDF, and disc replacement, which I know you love?
Well, I actually was going to kind of ask around for all the institutions, is what percentage of these patients are actually well indicated for foraminotomies. We just don't see a whole lot of them. Our major back and forth is between disc replacement and fusion, which in Rick, Jack, and my practice is about 80-20 disc replacement to fusion. The group probably about 50-50, I would say. But I would say that maybe less than 5% at TBI is foraminotomies, and that may even be overstating. There's also a paper that came out in the last year or so, and it may have been the same Swedish spine registry looking at foraminotomy, ACDF, and disc replacement, and they didn't find a difference between the three in either adjacent segment, albeit they only had like 1 to 2 year follow-up. And again, the re-op rate was higher with foraminotomy, but otherwise it was all pretty equivalent. But I'd be curious to hear sounds like you're doing a fair amount at Rush.
No, I mean, I'd still say probably of the sort of cervical surgeries, 10% maybe in my practice get a foraminotomy. I still do more ACDF and disc replacement, but Anyone on the call do more than 20% of their cervical surgeries for degenerative pathology is a foraminotomy? Raise your hands. So pretty uncommon. But I think partly, to be honest, it's just we love ACDF. It's easy, it's quick. Patients do well. Now we do them. They go home, outpatient, et cetera, et cetera. Anyway, in the interest of time, let's move on to the last talk, which is from Mike Nolte, another of our power residents going into spine. He's going to talk about a topic we all lie awake at night thinking about: bacterial infections and DDD and all that kind of stuff. It is a topical issue, and there's been a lot of research and papers written on it recently, so I think it's an important one to discuss. Go ahead, Mike.
Yeah, thanks, Dr. Phillips. Thanks, everybody, for sticking around. I'll try to move quickly here. Like Dr. Phillips said, I'm Mike Nolte. I'm one of the third-year residents going to be going into spine in the coming years. Today, I'm presenting a 2019 prospective multi-center case control analysis out of Sweden, including Dr. Fritzl of the Swedish Lumbar Spine Study Group, recently published in ESJ. As we all know, low back pain is a leading cause of disability and a burden to global healthcare systems, oftentimes attributable to degenerative disc disease. Typically, we think of mechanical, traumatic, genetic-based theories for why discs degenerate. However, there's been a recent push, as Dr. Phillips said, to kind of understand, could a low-grade bacterial infection be contributing to the etiology? And that's been based off of cultures of discs that have been removed and then post-surgically grow kind of indolent bacteria that are the most common contaminants. So it's an inherently difficult area of research. But people often point to this 2013 level 1 randomized controlled trial in which patients who had modic changes and degenerative disc disease who received 100 days of Augmentin reported low back pain scores at the conclusion of the trial, and should we be treating these patients simply with antibiotics? So in this study, they looked at, again, 7 Swedish hospital systems from 2015 to 2017. They had an experimental group of 40 patients with degenerated discs undergoing surgery for lumbar disc herniation, and then 20 patients who were a control group, and I think that's one of the strengths of this study, who were adolescent scoliosis patients otherwise undergoing surgery, who the surgeons could simply take a biopsy and swab sample from. They took swab samples from the skin prior to the formal scrub, the subcutaneous tissue, and the tissue overlying the vertebral lamina. And then they took 4 biopsy samples from each patient, from the vertebra and from the disc. The outcomes they looked at were bacterial growth and culture, and then they used a form of a procedural control in that they tested for evidence of bacterial DNA using PCR, and this was done at 2 independent laboratories. In terms of the results, this is figure 2. I'll first, on the left is your experimental group, on the right is your control group. I'll first direct your attention to the bright yellow. So 15% of patients in both cohorts had no bacteria in any samples, but the remaining patients all had bacteria at 1 or more levels. The light blue is probably the most interesting group. These are the patients who had bacteria only at the disc or vertebra. And then the gray are patients who had bacteria at the disc or vertebra in addition to another level. But basically what the authors concluded was that there were no major differences in the amount or the distribution of culture positivity between the experimental group and between the control group. Then looking at the procedural controls, 235 of the 240 samples were DNA negative on PCR analysis. Then of the 5 that were positive, only 1 in 5 matched the DNA of the bacteria that grew from the culture. And then they also looked at genetic relatedness, another form of procedural control, in 15 patients that had C. acnes, which was the most common bug by far in the study, at both the skin and the disc level. 5 of the 11 in the lumbar disc herniation cohort were the exact same strain, a fact that the authors were pretty impressed by. And they attributed the rest of them just to the thousands of strains of C. acnes that can be present at the skin at any one time. And finally, this is figure 3, looking at the relationship between modic changes and possible bacterial growth. On the top, you have your experimental group. On the bottom, you have your control group. On the far left, you have bacteria in surrounding soft tissue and disc. And then in the far right, you have bacteria only in disc and vertebra. Basically, when you're looking at this chart, you would expect to see that if bacteria were related to modic changes, we would see much more blue or orange, which refer to modic 2 and modic type 1 change, respectively, either in the far left column or the far right column, and we simply don't see that. They say that there is no difference in the distribution of modic changes across the 4 bacterial findings groups. So what do you walk away with here? There's an equivalent amount of bacterial growth found on both superficial and deep tissues in both the experimental and the control group. The majority of disc and vertebral body biopsies had no bacterial growth on DNA or no bacterial DNA on PCR analysis, which was your procedural control. And then none of the patients with modic type 1 changes had positive bacterial growth at the disc or vertebral body sample. And kind of the key takeaway that the authors wanted us to walk away with were that the bacterial findings in this study in adults with degenerated disc were more consistent with contamination rather than an organic low-grade infectious process contributing to their underlying disease pathology. In terms of some of the implications and whether or not this changes our practice, I think that the association between low back pain and low-grade bacterial infection may not be as strong as some of the studies that Dr. Phillips referenced have suggested. Especially in this day and age of antibiotic stewardship and a renewed respect for our infectious disease colleagues, we should strongly question the practice of treating low back pain and degenerative disc disease with antibiotics alone. Some of the positive effects that we've seen in previous studies may be due to changes in the microbiome or an inherent anti-inflammatory effect of the antibiotic itself. But in either way, I think we need to continue our efforts to understand this multifactorial nature of low back pain, which continues to be a challenge.
Thanks, Mike. Nice job. Well, no one's done more basic science than the disc than Howard. So interested to hear what you think about all of this, Howard.
So Mike did a very nice job, really spot on about the microbiome. Anyway, this is somewhat controversial, okay? I never believed that Albert study, treating with antibiotics for 3 months is because of discitis or infection. It's not. It's the disc problem. Modic change and all that related thing is inflammation, cytokine. You will never see a PMN or neutrophil in any of this specimen with DDD, whether it's an animal model or it's in a human. So I never believe it's infection. So I think though, because of this inflammation, macrophage and all the cytokine related inflammation associated pain and the DDD, there's a lot of interest in the research fields of microbiome. Microbiome in the gut, bacteria, whether it's a good flora or bad flora, is associated with Alzheimer's disease, you name it. At Rush, we are doing some microbiome-related disc degeneration research. So I think that when you treat with 3 months of augmentin, you are changing the gut flora, which affects the inflammation of the body, including your gum and disc. That's why you have less pain. Maybe it's an indirect effect. So that's how I interpret the Albert's, the controversial paper. And this is a negative study. It's really, I think that I'm of the opinion that this, degeneration is not infectious. So that sort of confirms my belief.
Thanks. And actually, Todd Albert's texting me, and he's saying that he was the Albert that treated.
Oh, no, that's Helena Albert.
He's claiming credit on the text. Ben, you're a disc guy, science. I'm glad you can see you now. What do you think?
Yeah, I agree with what Howard just said. I mean, I think it's a controversial area. I think, I won't go into specifics, but one of my colleagues wrote a paper too on the incidence of key acnes and got headlines for it being a very high number in routine cultures of the disc. But it was a small sampling of 7 patients and 3 of them had it. So, I mean, I think it's worthy of continued investigation. I'm a little skeptical with some of the conclusions that are being drawn. So I agree with Howard on that.
Gents, any comments?
Just as we're heading to the close, I want to congratulate your residents and fellows for excellent articles and great questions. The moderation and the comments from everybody were really cool also. And all the controversies raised are ongoing and will continue to be a very significant factor in our practices. No specific one to the disc inflammation, which is a fascinating topic and the causation of which is still not well understood. Clearly, an inflamed disc can be a focus for bacterial accruement. We see that in our multiple discitis and osteomyelitis patients here. So there is a correlation between inflammation and affinity for bacteria to start living in there. The causation part of the inflammation caused by bacteria, however, the reverse argument is still very problematic, and I completely agree with Howard's excellent analysis. Thank you.
All right.
Thank you, Rush, guys. That was a great journal club. Well done.
I'm thinking we should probably pick our fellows like this. It could be like The Voice, we turn around and pick our fellows that way.
Have to do the song and dance.
Your residence.
Right. Stay safe, everybody. We'll see you Tuesday night. Tuesday night.
That's correct.
Stay safe, stay healthy.
All right, everybody, take care.
Thank you, Alexis.
Bye-bye.
Bye-bye.